Our last talk before we close the session is on establishing a myopia clinic in your practice. I think it's one of the most important take-home talks we can do, but because of paucity of time, we're going to cut it short.
So any questions while I just set up? Any questions on any of the topics?
Better, yes. But there are no direct studies. I mean, the anecdotal evidence is that it is better, but there's no direct evidence. It will come next year.
Okay. I'm sorry. So for want of time, I'm just going to quickly run through my slides. So do we need a myopia clinic? If your OPD is 30% pediatrics, then there's probably 60 to 70% myopia in your practice, and then definitely you'll need a myopia clinic. What kind of patients do you register in your myopia clinic? Obviously the myopes, the lower than average myopes, or the so-called at-risk pre-myopes. We are looking at age-based hyperopia, which doesn't correlate, and of course all kids with parental hyperopia, whatever their refractive error is. First thing I do is always profile my patient. So these are the questions that I ask. These are the 8 subheadings that I give. I can share the questionnaire with you if you can send me your email. I have a pad and a paper there. So anyone who wants any of the materials that we have discussed so far, you can just put in your email ID and then we will send you across whatever you ask for. So this is the proforma that we usually have. We have an automated refractor, the acceptance, the cyclorefraction, fundus. We always do an A scan every 6 months, and we also ensure that questionnaire is done every 6 months. We do a thorough BV evaluation in our clinic, but the least we can do is at least do a MEM retinoscopy or a dynamic retinoscopy. I do have templates here for you to pick up and go for what I have, but if it's getting over, you can please send in your email ID and I can send it across to you. So this is how we do MEM retinoscopy, accommodative lag. You know, there is a near target, and then you just have to attach it to your retinoscope, and once you attach it, you just have to ask the child to read, and as the child reads, you do the retinoscopy with the correction. The refractive correction has to be there. If it is within plus 1.5, there is no accommodative lag. If it's above 1.5 or beyond 1.75 or 2, you have to correct for the accommodative lag, right? Okay, so now these are the tests that we do in our clinic. A lot of tests, but they roughly take about 20 to 25 minutes. Pretty easy if you're doing fast, and if you give the questionnaire to the parents, they don't complain, they sit there and they fill it on their own time, right? So this is how we do with a new patient. We do the regular refraction on the first visit. We don't do anything regarding myopia. We ask them to come back on another day. After cycloplegic refraction is when we establish myopia. We ask them to come back on another day. We do the myopia workup, and then we give the recommendations, whatever we have to. It's important to teach drop application because parents mostly don't know how to apply them, so the compliance and the effects change. So always teach how to apply the drops. On the follow-up visit, I always check for empty bottles because that is a short way of checking compliance, and we do the regular evaluation on the same day itself. So I don't call them up for another day for the second part of the myopia workup. So then you do the alterations or whatever you do. So I have a lot of case scenarios here. This is how we generally profile our patient. We do the age questionnaire, we do cycloplegic refraction, axial length and BV assessment, and based on this you can see for this child parental myopia plus 0.5, pre-myope, right? This is a pre-myope. So just lifestyle activities should do with vision therapy. So here you can see this is, I think, extensively discussed by Dr. Aditya, so I'm not going to go into that. This is what I give as lifestyle modifications for the child. Of course, the parents have to emulate the children. When it comes to near work, these are the factors that actually affect, and these are the factors again dealt with by Dr. Aditya. Again, visual hygiene. We talk a lot about visual hygiene. These are the things that I usually recommend in my OPD. I have it all on recorded videos. It's already there, so people just keep seeing it on loop. So this is case scenario 2. It's a new myope, minus 0.75 degrees diopters. Again, here I start glasses, lifestyle advice. I still don't start them on atropine on the first visit. But after 6 months, the same kid goes to minus 1.5 diopters. So it's a progressive myope. At this point, we can start them on atropine. I'm sorry, I'm just rushing through my slides. So we give daily dose of atropine, 1 drop at night, both eyes for 2 years. And then we continue them for 2 years, taper and stop. Okay, So once we taper, once we put him on atropine, it's fine. New thing that we see after COVID pandemic, despite atropine, they don't respond. So this is another thing which we are seeing post-pandemic. The atropine doesn't seem to be working. When we think atropine is the all solution, we suddenly realize it's no longer working in after the COVID. So there are challenges. So again, similar child who have progressed with atropine, on atropine. So here I always prefer to shift them to the DIMS lens. And we have good experience with the DIMS lens now, 3 months on, and I have around 8 patients who have come back to me and they are doing pretty well. So the promise is there, but we'll have to wait for the 6 months data. It's really easy, much better than atropine to manage. The compliance is good. Yeah, so she did well. So this is a new device that we have devised for monitoring sunlight in children. Again, goes more customized in terms of myopia control. There is an app that tells them how much of sunlight every day the child gets. So I'm just going to, these are all the, how much to talk, whom to talk. So this is going to be my final slide. Give a name for your clinic. Set one day, because you're going to be saying the same thing over and over again to your myopes. So you just set a day, put a video, make it on loop, train your counselor, give patient booklets, form a WhatsApp support group because they want to know that they have other supports. This is our Myopia Clinic. This is our Myopia pamphlet. I can share with you all of these details. These are comics which we use for promoting outdoor time, and customize your myopia control and establish a good myopia control clinic in your department. Thank you so much.